I'd now like to introduce Ansunette Pelser. She's a speech-language therapist with Cayman Theraplay. She'll be presenting today on an important topic, shifting perspectives in assessment of neurodiverse children. She has a degree in communication pathology with specialization in speech-language therapy and a postgraduate diploma in rehabilitation and disability. She has training in early communication intervention, literacy, and in working with neurodiverse populations. And she's also received further training in dementia care, voice and swallowing disorders, and in successful training of caregivers. Ansunette, welcome you to the podium.
Thank you so much for that introduction, and thank you to you all for being here today. It is an immense privilege to be able to speak with so many different people. And
can we ask that we have the doors closed, please, so that the presenters aren't disturbed? Thank you.
Thank you so much. So, as I was saying, thank you all for coming through today, giving up a part of your Saturday to discuss and engage with us. It is such a privilege being able to speak with and engage with people from so many backgrounds and from all throughout the health ecosystem. Thank you as well to the organizers for this opportunity, for the way that this conference has been run, and a special thank you also to my fellow speakers today. It's been amazing listening to you all, and I've really enjoyed hearing all of your perspectives, and it's reminded me that even though we all come from different backgrounds and we fill different parts of the healthcare ecosystem, we're all working towards a common goal. And having said that, I'd like to preface my topic today by saying that even though my specific topic focuses on children and neurodiverse children, my hope is that what we discuss will be an important tool in your toolbox, regardless of whether you work with children or not. And even if you are working and forming part of the healthcare ecosystem as someone who works in legislation and making sure that there are services that people can access. Even if you are here as someone who accesses healthcare services, which is the case for most of us at some point in our lives, I hope that what we discuss will allow you to look at the people you work with holistically and also allow you to advocate for yourself, your loved ones, and your clients or patients. So I also want to preface two more things. As I've said, I'm going to be speaking a lot about children, but we know that neurodiverse children become neurodiverse adults. As we have more understanding of neurodiversity, we understand that people have to access healthcare systems, and those people who are neurodiverse are often presented with major barriers and obstacles. So even if you work with adults, I think that this is an important topic to keep in mind. I also want to acknowledge that I myself am not neurodiverse, and I am speaking with a neurotypical brain and my perspective. And when we are looking at the neurodiverse population, thinking of their perspectives and hearing their lived experiences is always really important, and we should make space for that as well. So, as Dr. Ryan mentioned, we are wired for connection. And many of you might have seen this phrase. I think anyone who is a parent and on Instagram would have seen this on your Instagram parent pages, connection before correction. And as a speech therapist, I like it because it rhymes, sounds good to the ear. But what does that actually mean? What is connection? And why is that so important to us as healthcare providers? Think of it for yourself. When someone gives you advice, when the dementia specialist tells you to stop smoking, it's much easier to take that advice when you feel that this person actually sees you and acknowledges how difficult that might be for you because you're tired and this is your one thing for yourself, the one thing you have outside of screaming kids and a busy day at work. The connection is what makes it possible to correct. Now, in saying that, I firmly believe that connection can already take place during assessment. That's not something we have to wait for. It's not something we have to say, oh, in a couple of sessions after I've seen you 5 or 6 times, we can finally connect. Yes, connection might not be instant, but the way we assess our clients and patients, that allows us to build the foundations for connection. So, what we'll be discussing today and what you'll hopefully leave with today is being able to identify different factors that contribute to interaction through the use of the ICF, or International Classification of Functioning. We'll be speaking about this quite a bit because this is really the basis, really the basis for my presentation. We'll be discussing potential barriers we have when assessing neurodiverse children. We'll explore practical ways in which we can accommodate neurodiverse children when assessing them. And we'll also discuss how we can support neurodiverse children and their families following assessment using the ICF. So, we're going to be here for a while on this slide and the next. And we're speaking about the International Classification of Functioning. This is a framework and classification of health and health-related domains that is really wonderful. It is a dynamic framework, which is fantastic because we are all dynamic people. We are not static. It was developed by the World Health Organization and officially adopted by WHO member states in 2001. And the next phrase is really important to me. It was adopted as the international standard to describe health. And I know that for all of us taking time out of our Saturday morning, we want Cayman to ascribe to and reach the international standards of health. That is our goal. We want to offer world-class healthcare on the island. We want to offer best practice and evidence-based practice. What's also wonderful is that the ICF allows us to view health within the context of environment. No man is an island, even though we live on an island, right? So who you are is so heavily associated with and influenced by the environment around you. So let's take a look at the ICF model. My apologies again. I'm going to be pointing out some things here on the left-hand side of the room using the pointer. So, sorry, that was a technical glitch. At the beginning, when they went through this with me, they said, oh, it's a simple system. Apparently, we cannot underestimate how poor I am at technology. So, let's try that again. At the top there, you'll see it says health condition. Now, a couple of decades ago, when we were working within a medical model, that's all that really mattered. Someone came in, they have a diagnosis of stroke, high blood pressure, autism, and all you see is the diagnosis. I know what the health condition is, so there's a one-size-fits-all plan for that, right? But, as we've heard with our other speakers as well, this doesn't work. This is not sustainable. And what's going to happen then is we're going to have people coming back again and again and accessing services because what we're doing isn't working to really assist them, and it's not really meeting them where they are at. So that's why we have the ICF model. And as you can see, there are arrows pointing to the different domains. And I want you to take note of the fact that these arrows are not just pointing one way. They go both ways. That is because all the domains influence each other. It's also worth remembering and noting that as we age, as we move through different life stages, as our circumstances change, the participation in what we see within the ICF will change. Now, as I go through this framework with you, I'm going to use an example, and I'm not going to use a neurodiverse child right at the beginning, mainly because sometimes using an example of a condition that we all can visualize is a little bit easier. So I'm going to use the example of a patient who has recently had a spinal cord injury and a diagnosis of paraplegia. So we have someone who the health condition is paraplegia. How does that affect us? If we look at the body structures and functions domain, that speaks to how this affects your motor, cognitive, and affective abilities. Now, we all know that that means there's going to be loss of the lower limbs and loss of function in the legs. But these domains also affect each other. So take a moment to think of someone who has a diagnosis of paraplegia, but has not been trained optimally in how to do pressure care. What's going to happen is that we'll see something like pressure sores or bed sores are developing. That in and of itself is going to cause a new health condition. So those two domains are interacting at the whole time. We can also then look at our next domain, the activities and limitations domain. So activities speaks to self-care, mobility, and activities of daily living. So how does this person get around? Can they get around? How do they look after themselves? Can they dress themselves, engage in personal hygiene? Can they cook, clean, do the laundry, do other domestic tasks? Now, this is important because if you were the person looking after everyone in the house, and all of a sudden you have a health condition that makes that difficult for you. Maybe you were the person mowing the lawn, and now if you have reduced mobility, that's a little bit difficult. That's going to affect how you complete the activities in your day-to-day life. We next up have the domain of participation. And that speaks to our social roles, education, and employment. I want you to take a moment to think of the roles you fill in your life. Maybe you are a parent, a partner, a friend, colleague, employee or employer. Maybe you work for yourself. Maybe you have other social roles. Are you a member of a dance group? Do you play Gaelic? Do you have a book club? What is it that you do in your day-to-day life? What roles do you fill? Now think back to this person who has recently suffered a spinal cord injury. If they worked from home, they worked online, they could still probably complete their tasks. If they were a manual laborer, though, that's going to mean that their job has to be adjusted in some way. If one of their main hobbies was playing rugby, then that's going to be affected. That in turn will affect their social roles and how they're able to engage in social activities. And we've just heard how important it is as we get older to have strong social connections. Think of how that affects your mental health. That in turn can lead to a new health condition. So all of these domains are constantly interacting. And so as healthcare providers, we have to be on top of it. We really have to be thinking holistically all the time. And we almost have to be playing a little bit of fortune teller there and thinking about what could happen potentially, because we want to be preventative. At the bottom, I'm going to go from right to left here. We have personal factors. Now, personal factors are sex, age, and health behaviors. And specifically the sex and age parts, our clients or patients can't really do much about that. We are all aging, like it or not. But what do we know when we use the ICF? We know that as we age, there may be certain comorbidities that we are more likely to develop. There are things that we have to be thoughtful of. We also know as we age that we might be nearing retirement. That's going to affect our participation. All of a sudden, once you're retired, maybe you don't have that role as an employee or an employer anymore. That takes away one of your participation roles. Might take away a lot of your social roles as well. Again, we can't necessarily change the aging, but we have to be mindful of how that affects the people we work with. Same with sex. We know that there are certain conditions that males are more likely to develop than females and vice versa. We just heard that with our dementia talk, when we heard how likely females are to develop dementia. Finally, we look at the environment. Now, here I'm going to lean heavily again on the example of someone who has recently had a spinal cord injury. Environment looks at the physical environment. That includes the man-made environment. Are there ramps available for a wheelchair? Or do I live in a house with flights of stairs? Is it possible for this person to get into the shower without any difficulty? Or is that going to have to change? Because think about it. If you can just wheel into the shower, you can wash yourself. If you can't, you need support. That's going to affect your activities. We also look there at the natural environment. Think of going to the beach. Maybe this person is able to get as far as the car park, but if there's nothing available for them to be able to access the beach, then they can't enjoy it. That's going to have an effect on their social roles. Imagine you being the one having to look on as everyone else enjoys a day at the beach. We also have in that transport and technology. So what is the access this person has to transport? What does public transport look like for this person? What does personal transport look like? Do they have an accessible vehicle? We also think here about access to technology. For a lot of our clients who, and this is something that we'll see maybe with our neurodiverse population, we have to think about things like access to technology for communication, access to technology to help in the classroom. We also see here attitudinal and social environmental factors. And that looks at what's the attitude of your family and friends? What is the support you have in that area? What is the attitude of your employer? Are they supportive or are they placing barriers? Do they maybe not understand the needs you have? And very importantly there we have social. Now, social environmental factors refer to what systems are in place to support someone. And that, ladies and gentlemen, is where we come in. We are part of that system. We can be a resource, we can be a barrier. And as healthcare professionals, we have to do our best to be a resource in that. Do we know about what people have access to? Do we know about the accommodations available to people? It's our responsibility to know this in order to best support the people we see. So, now that you know about the ICF, you understand this model a little bit more, and hopefully you can see how you can use it regardless of who you see on a day-to-day basis. You can also use it for yourself, so that the next time someone asks you questions about your medical history, you know exactly what to say. Let's take a look at our neurodiverse population. So you'll see that I have two examples there. And if we were to focus simply on diagnosis, we would see two 8-year-olds, a girl and a boy. Both of them diagnosed with autism spectrum disorder level 2. But what they have as resources and what might be barriers for them are very different. And that's going to affect not only how we treat them or their presentation, but also our assessment. So if I look on the left, I see that the little girl also has a diagnosis of epilepsy. What does that tell me when I'm assessing? It tells me I have to be aware of what kind of epilepsy does she have? How often are her seizures there? Am I equipped to assist her if that occurs during an assessment? Are her family equipped? Do they have enough knowledge? We see that she splits time between 2 households and is an only child. So potentially, she gets a lot of time with parents as an only child, but it is split between 2 households. We don't know what it looks like in those households. What is expected in one household might be vastly different to what is expected in another. As someone assessing this child, I can then expect that maybe on the day when she's with mom, she might present one way. On the day she's with dad, she might present another way. We can't control that, of course, but it's something to be mindful of when we're assessing, because assessment cannot be one-dimensional, because these children we're working with are not one-dimensional. We see there that she's been in 3 different schools over the past 2 years, and for me, immediately that says, maybe there's a little bit of a barrier in her access to education. Maybe the support isn't there. Maybe the people who've been working with her didn't know how best to support her. Maybe there hasn't been enough education to give them the tools to support her. She doesn't have any other support services. She enjoys reading, has access to a tablet, computer, and transport, and has fair financial resources. So when I'm assessing her, if a part of my assessment uses reading, I'm going to probably start with that. I want to make her feel confident. I want to have her work from a place of strength, not from her weaknesses. I also know that I can give her technology like a tablet to utilize in my assessment if needed without it being something foreign to her. On the flip side, on the right we have the little boy who, same diagnosis, but has literacy difficulties. So conversely, I'm not expecting him to start off with a literacy assessment straight away. I might start with something else, something that he feels more confident in. We see that he's in a single household with 1 parent and 4 siblings. Now, this is not necessarily a good or a bad thing. It doesn't have to be a barrier or a resource, but we have to go ask questions around how much time is available to support him. You know, what are the attitudes of the family? How do his siblings and his parents support him? We see that he has a supportive school. That's something we can use to our advantage. He also receives occupational therapy intermittently, another thing to use to our advantage. When I'm doing my assessment, immediately I can go, oh, well, if he has a supportive school and receives occupational therapy already, maybe that means that before my assessment, I should contact these people. They might be able to give me valuable insight into what it is that I can do to allow this child to participate in the assessment to the best of his ability. Because that's what we want to do, right? We want our assessments to give us an accurate description of what this child can do. We also see there that there are limited financial resources and limited access to technology and transport. Now, I think that those of us who are attracted to healthcare as a profession or an interest, we all have a little bit of a bleeding heart, and there's a part of us that wishes we could just fix everything for everyone. And in an ideal world, we'd be able to address those financial resource limits. We know that that's not an ideal world. We don't live in an ideal world. What we can do, though, is that when we're assessing, we have to be thoughtful of the fact that the recommendations we make have to be in line with the resources this child has available to them. So that is just a quick overview of how we can use the International Classification of Functioning and its domains to really get more information. Because hopefully, after speaking through this, you'll agree with me that my assessment of the 2 children will look very different in how I structure it. And what I'm thinking about might also be very different. Now, as we continue, I want to touch on neurodiversity and what that actually means. So it, much like our first phrase of connection over correction, is something that's become pretty trendy over the years, and people might say and speak about neurodiversity, but do we actually know what we're talking about? And originally, this is a term that was based on the social model of disability, and it emphasized the differences in how all brains work. So all our different brains, they said, oh, the neurodiversity, all our brains work differently. However, now it has developed into an umbrella term, and that includes diagnoses including ASD, ADHD, dyslexia, developmental coordination disorder. And the most important takeaway here for me is that it values the differences between people, and it focuses on supporting unmet needs. When we value the differences, that means we are not trying to change. We are being accepting. We understand that this child or this adult's brain works differently to mine. That is okay. When I am assessing them, I'm not trying to make them be like me. I'm not trying to get them to access the world the way I do. Instead, I'm accepting that the way they see the world and might interact in the world is different to how I do. I am simply there to support their unmet needs. We never want to change who a person is. What we want to do is we want to give them the tools to access the world in a way that they feel comfortable with. Because that's the thing, is that some of our children who are classed as neurodiverse, they don't have the tools. And so they might be standing on the outside looking in, thinking that they want to access that social interaction the way their peers do, but they might not know how. It's not about taking away their special interests, taking away the things that make them them. It's about saying, hey, this is how you can engage within the boundaries that you want to set. So I thought that this was quite a nice visual of what neurodiversity includes. And as it says there, dyslexia, developmental language disorder, tic disorders, intellectual disabilities, ASD, DCD, and dyscalculia are all there. And as we learn more about neurodiversity and we have more and more activists and people with lived experience coming to the forefront, we also see that this umbrella term is becoming wider and wider to encompass more conditions. So, some statistics about the neurodiverse child and why this is such an important topic for us. As we see more and more neurodiverse children walk through our doors, we know that some conditions are associated with additional health risks, including mental health difficulties. A UK study from 2024 showed that children with ASD have a 5 times higher risk of poor health than their peers. That is a very significant amount. And a lot of this is around things that are preventative. Okay, so why are we missing out on these kids? There's a barrier for them in accessing healthcare. And like I said earlier, neurodiverse children become neurodiverse adults. And in 2019, it was found that autistic adults experience barriers in accessing healthcare. And so we have to start looking at how we assess these people. We also see that there's a decreased engagement in preventative healthcare within neurodiverse populations. Now, it's easy to say what to do, but we have to address and acknowledge that there are barriers. It's not always easy assessing a neurodiverse child. So, just going to speak through a few of the barriers, and I want you to think about your setup and how you might be interacting and assessing. The first thing is, assessment starts before the person enters your room, and it continues well after that. I mean this both physically and on a more abstract level. So when you first get the call that this person is going to come to you, this child who's neurodiverse is coming to you, are we asking the right questions? Are we setting ourselves up for success and getting feedback and information about all of the different domains that we speak of in the ICF? Or are we just looking at a few of them? Because the more you know before, the easier it is to set yourself up for success within the assessment. Also, practically, if a neurodiverse child is in your waiting room and it is busy and it is loud and there's a lot of sensory input, and then they come in and they have to do an assessment, that can be really tough for them. So, what can I do? I can't necessarily change the fact that this child has sensory sensitivities. I can't change the fact that there are other people in the waiting room. What I can change is I can say to the parents, so I know your kid's coming for the assessment and you've said that they're a little bit sensitive to loud noises. Do you have headphones you could bring along? Is there something that calms them or a comfort item that you could bring along? Sometimes the waiting room can get noisy. Could you time it so that they come just at the right time? I know you have forms to fill in. You can fill them in while I see your child. You don't have to fill them in beforehand, or I'll email them to you if I really need them beforehand. It's thinking about those little things we can do. We also know that communication difficulties may limit information shared. So we have to be thoughtful here about things regarding, does this child have an assistive communication device? Are we giving them and their parents enough time to speak and engage? We also have to be mindful of any associated conditions that may interfere with participation. The next one, I think, regardless of where you are working, we can all agree with, is that we have limited time available. In an ideal world, we would spend hours with our assessment, but that's not always possible. So being mindful about what you wish to do with the time you have available and thinking, what is it that I have to prioritize? Something that is also a reality is that for a lot of us, a child doesn't have a formal diagnosis before they come to us. And so we are potentially going to be assessing a child who is neurodiverse that we did not know that beforehand. So that makes the preparation tricky. So this is where it comes into being ready, having your resources, knowing how you can best assist someone if they come in and you realize, oh, we need to give some support. Another barrier that I think a lot of us have seen is that standardized assessments are not standardized for neurodiverse individuals. So I don't know how many of you are familiar with that Einstein quote about if you judge a fish by its ability to climb a tree, the fish is going to spend its life thinking that it's not worthy. So we have to think about what we are using to assess neurodiverse children. We also know that when analyzing results, the tendency is there to look at differences rather than at strengths. Now, yes, an assessment is there to show us the areas where someone needs support. That's totally accurate. However, how do we get someone to engage? How do we get someone to improve? We use their strengths. We look at what they can do and build on that. If I had to ask you to write an essay in a foreign language that you don't speak, would already be difficult enough. If I now did it and said, oh, but you also can't do it with your dominant hand, I'm making it even more difficult. Give someone access to the strengths they have. We also need to move away from the paradigm of neurodiversity as something to be fixed. This is where we become neurodiversity affirming. And that is something that, as healthcare providers, we have to take the lead in. And it's a tricky thing sometimes because it means moving away from that medical model even more. And it means we have to engage and ask questions, and we have to trust the lived experience of the people we work with and the populations we work with. So, how can we use the ICF in assessment? We see the barriers, it's all very disheartening. What can we do in real life? So first of all is make sure to ask for information on all areas of functioning. And we probably think we do it already. I think that sometimes experience is a wonderful thing, but experience should never just lead to comfort or complacency. And we can always think, oh, what can I ask differently? How can I ask it differently? Knowing that when we're working with a neurodiverse population, some of these children we work with might be very literal in how they understand certain things. So asking the right questions, but also asking it in the right way for this person. It's really important to go look at all the roles someone has to fill. So when we just assess a child based on their academic or scholastic performance, and we discount their role as a sibling, a child, a rugby player, an anime fanatic, a gamer, that's about half of the kids I see, we're discounting a lot of them as a person. Adapt the assessment environment. Make sure that you have things that can assist a neurodiverse child. This includes something like having headphones available if they're sensitive to noise. If it's a child who does well with deep pressure to help calm them, do you have a weighted blanket that you can give them? Are you making sure that if it's a child who's averse to strong smells, that hopefully you don't have a ton of disinfectant that you just sprayed before they come into your session? Little things like that makes all the difference. Because ideally, when we're assessing someone, we want to do it at their best. We want to give them the benefit of the doubt, right? We also have to understand accommodations available in other environments. So think back to the little boy that we were speaking of, who had this really supportive school environment. If I'm assessing him and I want to look at his literacy, I might have him write something, but if I know the school allows him to have a scribe, I might let him also do the same question or a similar question where he has a scribe, where he dictates to me, I write down, and he has to check what I wrote. Because that's going to give me good information about what he can do within the environment that he's in, with the accommodations he has. Incorporating special interests where possible is the same. That's where the connection before correction comes in. If I know that this parent told me, my kid loves Roblox. It's all he talks about. Now, I know nothing about Roblox. I have a ton of kids who do know a lot. And I might not know anything about it, but I can utilize that in my assessment. I can, if there's just something unstructured that they have to write or talk about or read, why not give them something about Roblox? Sure, give them something about something else too to get that contrast and comparison. But we don't have to discredit their special interests, which is something that, when we're not neurodiversity affirming, is very easy to do. It's very easy to say, well, we all have to be able to read about the botanical gardens, so we'll all read about that. Why not incorporate special interests? What's the harm? We all have special interests. I'm a 35-year-old woman who loves Taylor Swift way more than I should. That's my special interest. And it doesn't interfere with my functioning. But when I'm chatting with my friends, I definitely tell them about that. As I've mentioned before, it's helpful to incorporate observation to supplement standardized assessments. This is especially important considering we don't have enough standardized assessments for the neurodiverse population. It's quite heartening that we're seeing more and more assessments become available that are looking specifically at the neurodiverse population, but we're not there yet to have enough of them. Within your scope of practice, investigate if there are available assessments for the neurodiverse population. We know about the ADOS, which helps in diagnosis of autism. Then we also have the CAT-Q and the RADS-R. So both of those are checklists that people can fill in themselves to help identify potential autism. diagnoses, the CAT-Q specifically looks at masking behaviors, and it can be used with adolescents 16 and up, as well as adults. The RADS-R is specifically for adults. And then, as I said, being neurodiversity affirming in your approach. So we're not there to fix, we're there to support. We can also use the ICF after assessment. Utilize strengths in feedback and intervention. Be mindful of the fact that the parent of a child who is neurodiverse has probably had so much negative feedback over the course of their child's life. They might often be hearing how their child is lacking. You can be the practitioner that reminds them what their child's strengths are and how you're going to use those strengths to help support. Being mindful of the resources and limitations available. Again, we have an ideal world, but we also know that that world does not exist. We have to think about, if you only have this financial resource, we have to prioritize these interventions at this time. So, as I said, resources and limitations may affect frequency of intervention, access to intervention, and prioritization. And if we remember that the ICF is dynamic and it changes over time and in terms of where someone is in their life or where they are environmentally, we know that that prioritization might also change. It's helpful to formulate goals with the ICF domains in mind. We have to think of all the roles this child has to play. And as a practitioner, if we're only working on the child in the home or the child at school, we might be missing out on other areas where they need support. Remember, your client and their functioning is at the center of the ICF, regardless of diagnosis or impairments. We don't have to look at diagnosis and impairments as the be-all and end-all. How this person, how this child is interacting, and what their environment looks like, that's going to be one of the ultimate markers of success of intervention. So, thank you so much for engaging with me in this. Have a wonderful day.
Thank you very much. We do have time for a couple of questions. If we do have, just signal by not only raising your hand, but wave it a bit, because there's a bit of glare, so I'm not always able to see. And we can get the microphone to you. Going once. Going twice. If not, Ansunette, any final thoughts that you'd like to leave us with?
I think the most important thing for me that I would love you to walk out with today is knowing that the International Classification of Functioning is such a helpful tool, regardless of what population you're working with. It is available on the World Health Organization's website. It's a great little cheat sheet to have. It can be used not only for your patients, but for yourself. And like I said, neurodiverse children become neurodiverse adults, and we have to be prepared to assist. Thank you very much.
Thank you.